We are recording. Okay.
Hello, HCAPs, and welcome to another installment of the HCAP Speaker Series. I'm Eric Youngstrom. I was a professor at the University of North Carolina at Chapel Hill. I'm the co-founder and executive director of Helping Give Away Psychological Science. Now I'm at Nationwide, where I'm the new institute director of the Institute for Mental and Behavioral Health Research. All of those institutions are big fans of HCAPs. And all of the people in HCAPS are big fans of our guest speaker, Dr. Jessica Schleider. Dr. Schleider also recently has made a move. She trained with John Weiss at Harvard. She got tenure as a professor at SUNY Stony Brook, where she was doing groundbreaking work that caught pretty much everybody's attention. She's a recent recipient of I forget the exact title, Young Investigator Kickin' Butt Award from the National Institutes of Health, and just moved to Northwestern University, where she's the director of a center focused on bringing interventions to more people who actually will be able to finish them and benefit from them. She's a fantastic researcher. She's also very active on social media. And so many of you are already following her on Twitter, or now X. Everything is changing. And if you're not already following her and you want to see what it would look like to see good science through social media, check it out. Without further ado, it's a delight to give the virtual microphone to Dr. Jessica Schleider.
Thanks so much, Eric. I'm such a huge fan of HGAPs and everything you stand for and the work you do. And as you'll probably see as I go through my slides, we share a lot of values around how and for whom science should go. So I'm just going to share. Oh, if somebody could allow screen sharing, I would greatly appreciate it. I'm happy to just talk, but probably more fun for you if you can also see.
Phoebe, are you still with us? One moment. Very sorry about this.
No worries.
It's the magic of
This is kind of like what the whole onboarding process feels like. How about for you too?
Yes.
My
Slowly but
big
surely.
accomplishment week one was locking myself out of everything, and I mean everything.
Yeah.
I separated my keys onto two lanyards and biked home and realized that I'd left the fob for the apartment at the office along with the keys for the
Of
car
course.
to try to drive
Perfect.
back to, yeah, it was quite spectacular.
I have sharing privileges now.
All
This is
right,
great. Okay.
back to science.
All right. Is that all? Is that coming through okay?
Sure
yeah.
is.
Okay, perfect. I will just dive right in. So first off, this is labeled disclosures because that's the required label for this page, but this is really a thank you slide for the many folks who've had confidence in the work that we are proposing and have partnered with us to make it all possible. And below, I do quite a bit of consulting on helping different organizations across different sectors, industry, nonprofit, and academic, disseminate some of the single session interventions I'm going to be talking about today. And we also try to disseminate what we do through books. So with that, I will dive right in. I was trained as a child clinical psychologist, and in that process, I grew intimately familiar with the systems that youth had options to pursue mental health care in. experience with those systems firsthand just left me incredibly frustrated at the many ways in which current mental health care systems are totally inadequate for meeting youth mental health needs. And that's really what drives a lot of the program I'm going to be talking about today. But where I want to start is what we need to think about when we think about expanding youth mental health care ecosystems and the three really difficult realities that we face in trying to embrace that challenge. The first reality is that between 50 and 80% of youth with mental health needs in the United States don't access any form of mental health support whatsoever. That's an unacceptable statistic on its own, and we could just stick with that reality, and that would probably alone justify what I'm about to share. But there's some other factors that complicate the picture. Reality two is that the supports that do exist, which are only accessed by a small subset of young people, are often structurally incompatible with how many youth actually want to engage with mental health services. In a recent qualitative or mixed methods study, our lab asked a sample of more than 200 teens if they could describe to us their ideal mental health support. What would that look like if they could build it from the ground up? And what they did not say was once weekly therapy with a provider. They said things that were more like, I want to be able to access support whenever and wherever I want it and as needed. So I can just sort of on demand access supports rather than having sessions once weekly, which may or may not coincide with when I'm actually wanting care. They also want to be able to access things independently on their own. And youth really are disempowered to access mental health care services on their own in many ways in our system. The third reality is that the most common number of interactions with mental health support that people do have once they access care happens to be one. This is in stark contrast to the average number of sessions in an evidence-based mental health treatment, which ranges from 12 to 16. So overall, we've done a pretty poor job of building supports that match how people can actually interface with care. Whether or not we want them to only receive one is a different issue, right? But we only have the system that exists today, and we have to figure out ways to make that system work for more people, even if it's not the one we prefer. So given these realities, our lab's mission at the Lab for Scalable Mental Health is to design, test, and disseminate brief barrier-free interventions to really reduce mental health problems at scale. At the population level, rates of youth depression, anxiety, and other common disorders really haven't shifted in a good way in decades. If anything, they've increased, particularly in the past decade or so. And to accomplish these goals, we take a pretty specific approach in focusing in on the smallest possible dose of intervention that can still be helpful to youth on a broad scale. And that's what really brings us to single session interventions. And I want to share a brief definition of SSIs because I actually never learned one when I was a graduate student myself. I learned this through that frustration-driven research that I did on my own. We understand SSIs in our lab as specific structured programs that intentionally, and that's key, involve just one visit or encounter with a clinic, provider, or program. I say intentionally is key because attending an initial intake or assessment session that's supposed to be the start of a multi-session course of treatment and then not being able to continue, that wouldn't be considered an SSI because there was no intention shared by the patient and the provider that maybe this is all we have this first session and we're going to make the most of it. SSIs can be accessed on one occasions or on many occasions. That is, this is a one at a time approach to treatment, not a one and done approach to treatment. There's no expectation or assumption that somebody should be all better after one session, but there's still the acknowledgement that one session can make a dent that matters. SSIs can be self-guided or human facilitated, and they can be accessed either within or outside of formal healthcare settings. But in all of these cases, SSIs drop this often false assumption that clients can and will always be able to return for session 2, while instilling the belief that meaningful change is in fact possible, even in brief moments. And fortunately, SSIs aren't just a nice idea, they're also backed by decades of data. In 2017, I published this meta-analysis synthesizing the results of 50 randomized controlled trials that all tested single-session mental health interventions for young people compared to control conditions. What this graph is showing you is the comparison between the average effects of single-session interventions for young people's anxiety, conduct problems, and depression, those are the blue bars, compared to the average effects of full-length psychotherapy in young people for anxiety, conduct problems, and depression. Those are the red bars. The first thing you probably notice about this graph is that those bars are strikingly close together, as in, alarmingly, single-session interventions don't appear to be having a markedly different effect than their multi-session counterparts, which on the glass half empty side, raises the questions of what are we doing in those extra 15 sessions and why aren't they helping more? But from a glass half full perspective, this is incredibly exciting because what it does suggest is there's something to be captured within a single session that we can potentially figure out and optimize and ensure that for the many people who only access one session, maybe that session can be optimized to matter. I want to note before I move on that I'm not saying and I'm not proposing that single session interventions can or should replace any other forms of mental health treatment that are currently available to people. But the reality is that the current forms of treatment that are available are totally not enough, and they're never going to be enough. So single session interventions can play a really important additive role of bridging these otherwise unfillable gaps in mental health care ecosystems for people stuck within or outside of systems of care. Over the past 5.5 years, our lab has been hard at work at trying to figure out how we can make single session interventions as helpful as possible. And to summarize what we've done to date, we've developed a suite of different evidence-based single session interventions tested across multiple randomized controlled trials that have reached now more than 50,000 youth, young adults, and parents. And most of these interventions are self-guided online modules that people can complete without a professional therapist or any therapist. One of our interventions, which I'll also talk about, is a lay healthcare worker delivered intervention that you don't have to have a PhD or even a master's degree to deliver, that anybody can be taught to deliver, thus enhancing their potential for scaling and reaching more people. About 15,000 of the people who've completed our single session interventions have done so through grant-funded randomized controlled trials, or RCTs, but the lion's share, 35,000 or more at this point, have reached our SSIs through our nonprofit and community partnerships. This has been partly supported by the fact that we've had wonderful international collaborators who've now helped us translate and culturally adapt our SSIs into 8 different languages, which has allowed us to reach folks across the world. 2 of our single session interventions, both of which target adolescent depression, were recently certified by Blueprints for Healthy Youth Development as being dissemination ready, which I'm particularly proud of. What dissemination ready designation means from Blueprints, which is a nonprofit independent evaluation organization that evaluates the evidence base for mental health treatments for young people, is not only are there multiple randomized controlled trials suggesting that these interventions can be helpful at reducing depression, but also the materials for the interventions are all publicly accessible. So the interventions are ready to disseminate immediately today to anybody who wants to take them. Our interventions have been built by a co-design with mostly minoritized youth, particularly with LGBTQ+ teens, because that tends to be a majority of folks who actually access our interventions once we make them freely available. We're pretty sure this is because we make our interventions available to young people, whether or not they involve their parents. And I'll get to this soon, but young people often cite their parents as major barriers to mental health care access, particularly youth who belong to minoritized groups or have minoritized identities. All of our SSIs are accessible as needed with or without parental involvement for free on the internet. These are some logos of the ones we've created to date. They target a variety of different bite-sized elements of longer-term psychotherapies like behavioral activation or the idea, psychoeducation around the idea that symptoms are malleable rather than fixed, or problem solving, really simple skills that on their own can have an impact. But collectively, each of these SSIs targets a modifiable short-term belief or behavior, whereby short-term improvements in that short-term belief or behavior, such as a perception of control over emotions and behavior, or a sense of autonomy, or a sense of hope for the future. Those mechanisms spur upward spirals of meaningful longer-term change that we've found detectable up to 9 months post-intervention, which is pretty good for a 20-minute self-guided activity. One example of a randomized controlled trial that we've conducted on our SSIs is one that we conducted during the height of COVID-19. The reason that we wanted to do this during COVID was because there were youth across the country, particularly after the initial lockdowns, who were actively losing access to mental health services that they had previously. So we wanted to see if our online self-guided SSIs had potential to fill some of those gaps that were being created by the pandemic in mental health service access. So we were able to secure National Institute of Health funding to run a randomized controlled trial, including 2,452 adolescents, all with elevated depression symptoms from all 50 states. You can see a map of our participants on this slide. We recruited all of them through Instagram, and we were able to secure a waiver of parental consent requirements for this study, meaning normally when you do research with young people, you need parents to sign a consent form. We were able to make the argument on ethical grounds that we couldn't really restrict adolescents' access to these low-intensity, potentially helpful supports just because they weren't comfortable sharing their need for support with their parents. So we were able to allow teens to self-refer into the study, and we've secured waivers for all of our randomized trials with teens for SSIs ever since then. What this parental consent waiver resulted in was a sample that was majority minority, which you normally don't see in youth mental health treatment research, but we believe that the consent waiver that we were able to obtain was the reason that historically underserved youth that have often been excluded from research were able to take part in our study. So our sample was 80% sexual and gender minority youth and 50% racial and ethnic minority youth. And in this 3-arm trial, we tested 2 single session interventions and a control group to see if the 2 SSIs, which taught growth mindset, the belief that depression symptoms can change simply because of how our brains work, and behavioral activation, the idea that what we do shapes how we feel, and therefore we're not stuck in low moods. We can always take a step to help ourselves. Whether these 2 SSIs could reduce depression, anxiety, trauma symptoms, and restrictive eating compared to a supportive control. The control condition here, because it's always important to know what you're comparing things to, was a placebo single session intervention, a 20-minute self-guided online activity that suggested that sharing feelings is good, but taught no specific skills. So it was designed to feel like what teens imagine therapy to be. So now I want to back up a little bit and explain how we build single session interventions to optimize their likelihood of having some kind of detectable mental health effect, both in the short term and the longer term. And we've organized our thinking around this and came up with an acronym called the best elements of SSIs for youth mental health. And we've drawn these components that we embed in all of our single session interventions from social psychological research, marketing research, and affective science to make sure that we're creating interventions that can be as impactful as possible in a short period of time. What BEST stands for is we use brain science to normalize the concepts we're teaching and strengthen adolescent buy-in. This way, we're not just saying we're adults and you adolescents should listen to what we say and how we think you should cope with stress. Rather, we're simply sharing educational material, statistics, brain scientific information to allow them to draw their own conclusions about why and how the skills we're teaching might help them. It also normalizes the skills that we're teaching, as in these skills apply to everybody because all of our brains work in the same way. And all of us have neuroplasticity, for example, the potential for change. E is for empower. As I mentioned earlier, youth are often disempowered in mental health care systems, as in they have little choice or autonomy in where to seek help or when they can seek help without going through adults in their lives. So these SSIs flip that and ask youth for their coping advice and guidance on explaining these potentially helpful concepts to others their age. So honoring teens' lived experience, and elevating them to a helper or an expert role rather than the patient role that they're used to. They've been in treatment before. S is for saying is believing exercises, which we use to solidify teens' learning. Saying is believing exercises are commonly used in social psychological research, where in these programs, we essentially give teens a hypothetical scenario of a peer struggling with a setback or a challenge related to mental health. And we have the teen use what they just learned in the program to give advice to this struggling peer about how to cope more effectively with their situation. And by teaching the skill, they are thought to internalize that skill themselves a little bit more. T stands for testimonials, so stories from others, particularly others with shared lived experiences and shared identities, so that they can see themselves in the intervention content that we're teaching and feel related to the content and skills. All of these elements that I just outlined more succinctly reflect self-determination theory, which is a theory that's well tested and well validated of underlying behavior change. And this theory suggests that we all as humans have basic psychological needs to feel competent, autonomous, and related to others or supported. And those are the short-term mechanisms that SSIs have been shown to impact. They help people feel a little bit more competent or able to make changes in their lives, a little bit more autonomous, as though what they do matters for their future, and a little bit more related, like they're not alone and others might understand them. In turn, those shifts underlie motivation and behavior change. And we've seen it across multiple studies at this point that short-term changes, particularly in competence and autonomy, help explain clinical changes after single-session interventions months later. Just to give you a sense of what are in single-session interventions that we've built, these are some screenshots from Project Personality, which teaches malleability beliefs about depression, and the ABC project, Action Brings Change, which teaches behavioral activation. We include brief lessons on neuroplasticity, emphasizing that everyone's brain is a work in progress and we all have potential to make new connections. We also draw on evolutionary science, explaining that our brains are wired to protect us from danger, but sometimes that goes on hyperdrive and our brains end up telling us to retreat from situations that aren't actually dangerous, which can lead to avoidance cycles and thus lower our mood. We include stories that we've gathered from teens who've been kind enough to share their own experiences of mental health with us. And teens can either read them or listen to them, depending on their preference throughout the programs to understand how these skills would look in real life. In the ABC project, which teaches behavioral activation, we also have a built-in behavior experiment and personalized action plan. We first ask teens to rate their mood on a scale of 1 to 10, with 1 being the worst mood, 10 being the best mood. They then can pick to watch one of 3 carefully selected adorable or funny or uplifting videos. This one you see here is of a really cute porcupine eating pumpkins on Halloween and making very adorable squealing sounds that you don't expect porcupines to make. It's wonderful. Has millions of views on YouTube. I highly recommend it. And then we ask them to rate their mood again. And automatically, if we detect that the teen's mood has increased even by 1 point, they get automatic feedback in the intervention that goes something like, wow, you just watched a porcupine for 30 seconds and your mood detectably changed in a good way. Imagine if you took the time every day to connect with people who make you feel good, to do one action towards a goal you care about, and to do something just for yourself because you deserve it. How much that could impact your mood over time. And they're then guided into making a personalized action plan to do just that. And they end up with a behavioral activation coping plan that they can use in their everyday life. We also include these saying is believing activities at the end, where we include some stories or examples of peers experiencing challenging scenarios like being rejected by others, and also experiences of feeling stuck in a low mood. And teens are invited to offer their best advice based on what they just learned in the program. So in Project Personality, one teen was asked, based on what you've learned about the brain and our ability to change, what advice would you give to somebody who felt rejected by somebody who they thought was their friend? This adolescent said, I would tell them to remember that even though it feels like these things will never end, nothing is forever. Maybe by being nice to the kid, you can help him realize that he's being mean and his neurons will help him change for the better, suggesting that they did internalize the idea that brains can change and therefore behavior can too. I already mentioned what we compare this to. Our placebo control is called the Sharing Feelings Project, which is designed to control for non-specific aspects of doing an online intervention like this. So it doesn't give away the intervention condition. So what did we find in this trial? Well, first, we looked at immediate impacts of the interventions on those short-term mechanisms that we have seen impact longer-term change. And we found that both SSIs, both of which were 20 minutes long compared to the placebo control, significantly improved hopelessness from pre to post intervention and significantly improved a sense of agency from pre to post intervention. In this case, what I mean by agency is perceived ability to solve problems. Our primary outcome of interest was depression symptoms, which we were very interested in 3-month follow-up increments. So we found that both interventions significantly improved depression symptoms across 3 months compared to the active control. I want to point out that an effect size of 0.18 is small. That's a small effect on average. But that's because our control condition was not nothing. Our control condition actually had within group effect sizes that were Cohen's D's of 0.3, whereas our active interventions had effect size that were that had effect sizes of closer to 0.5 or 0.6 Cohen's D. So we were outperforming with our single session interventions, something that wasn't nothing, which was really exciting to see. Project personality also had significant effects on anxiety and COVID-related trauma symptoms across 3 months. And to our surprise, both interventions significantly improved restricted eating across 3 months, which unfortunately in our sample was present in more than half of adolescents in the study without even selecting for it. That's since led to some more work on eating disorder focused SSIs, which I won't get to talk about today, but it's really exciting to see that that is another possibility of SSI's impact. Because we had such a diverse sample in this big trial, we were able to test equity in acceptability and effectiveness outcomes. And we were so pleased to see that neither acceptability nor effectiveness differed at all by race, ethnicity, gender identity, or sexual orientation. And the paper on that was just published by Riley McDaniel, one of my wonderful PhD students in clinical psych science. What that lack of a difference does bring up, though, is are there any factors that predict who an SSI is going to work for? Do online depression SSIs work better for some groups than for others? And we've been able to collate data from, at this point, dozens of small and larger randomized trials to try to test this question. And unfortunately, all I have for you is a list of things that don't consistently or at all moderate outcomes of SSIs. So baseline symptom severity does not moderate response to single session interventions. This was a surprise to me because I went into this work assuming that a brief intervention would be maybe helpful for lower intensity or lower severity problems, but not for more severe problems. First of all, we don't find that at all. And second of all, if anything, folks with more severe difficulties who perceive an active need for help are more likely to try a single session intervention when it's freely available on the internet. So if anything, there's a moderating effect of uptake favoring people who have more severe difficulties. Likewise, the presence of self-injurious thoughts and behaviors has no impact on whether somebody will benefit from an SSI. Neither does parent psychopathology or other parent-related factors, or receipt of concurrent treatment, like medication therapy or both. One of our other wonderful graduate students, Isaac Ahuvia, decided to explore whether we could take a machine learning approach to potentially get at this question of can we match people to SSIs that best fit their problems? Or do some SSIs work better for some kids than others? In that trial that I just shared, because we had 2 different interventions, a behavioral activation intervention and a a growth mindset intervention, presumably those might target different mechanisms of change. So we thought that those might differentially benefit different people based on their symptoms and characteristics at baseline. So we tried to build a personalized advantage index algorithm, testing hundreds of potential predictors of response to specific interventions to see if we could predict who responded better to which program. But the response predictors in this case were so similar across the single session interventions that treatment matching, we concluded, would have added almost no value. So what we concluded here is that maybe the best bet is not precision treatment when it comes to SSIs, but just increasing youth access to both digital SSIs and allowing them to choose. Given that autonomy seems to matter for how these interventions work, offering that added layer of autonomy and allowing teens choice might be more clinically beneficial than trying to match teens to their best fit SSI. So that's a little bit about, how we go about evaluating SSIs from an intervention science perspective, how we go about building them and positioning them for impact. But the other half, or 90% actually, of real impact of SSIs is not in their clinical effectiveness, but in their potential for dissemination and implementation. And that has prompted a real shift in the research program that we have around how to scale up SSIs. And we are trying so many different things, from social media integration to making them free, to creating drop-in SSI centers, to integrating with primary care, to commercialization and government partnership. But what all of these efforts collectively are helping us figure out is the context, conditions, and populations where SSIs do and do not bridge gaps in healthcare ecosystems, as well as what is needed in order to sustain these interventions as part of systems of care. So our first attempt at dissemination was just to make everything free. And that felt like a really important aspect of our mission as a lab. It felt very wrong to just be evaluating these interventions in the context of studies and not allowing anybody to access the interventions known to be helpful outside of those studies. So our lab pretty early on created a website called Project Yes. Project Yes stands for Youth Empowerment and Support. We've set this up as an ongoing anonymous program evaluation project where anybody can choose to try any of our SSIs that have been tested in randomized trials and found to be helpful. They don't have to give us data if they don't want to. They can skip all of the questionnaires. And making it a program evaluation is a mechanism for us to get continuous feedback from folks who want to give it to us on our interventions, while also ensuring that they're continuously publicly available. And this has been deemed by multiple universities to be non-human subjects research because we don't collect any identifying information whatsoever from participants. And our goal is not to evaluate the efficacy of interventions, it's to collect acceptability data and usability data over time. How Project Yes works. First, we ask users to choose an activity. So they can pick one of 4 currently 20-minute online activities. Then they tell us what they think if they want to. So before and after each activity, we ask teens some questions about their mood, their thoughts, and what they thought of the activity, but they don't have to answer any of that, of course. And then we have them share their best advice. So based on what they've learned from the program they chose and what they've experienced in their life, they can give anonymous advice to other teens and see it posted on our Project Yes Advice Center for others to learn from. And if you click on Project Yes Advice Center, it's kind of uplifting just to scroll through the hundreds of pieces of advice we have from teens all over the place at this point. And we're really trying to capitalize on that mechanism of people glean benefits actually from being a helper or volunteering or helping others. We've done a few pragmatic evaluations of Project Yes, both when disseminated via social media platforms directly to teens and in partnership with the city government. So the City of San Antonio Metropolitan Health District worked with our lab, and we partnered to translate and adapt all the interventions in Project Yes into Spanish and include San Antonio youth's personal narratives into the intervention. So it felt very relatable to the teens there. In both cases, we've found repeatedly that the interventions are acceptable. They result in short-term improvements in self-hate and hopelessness, perceived control, perceived autonomy, and folks consistently want to recommend the SSIs to others. Okay. Another avenue to dissemination that we've considered and are continuing to explore is by not just targeting adolescents, but also targeting parents of younger children. In order for SSIs to be optimized for public health impact, it's going to be important to target multiple sort of developmental periods, particularly key developmental periods in the onset of certain difficulties. Adolescence, super key difficulty in the onset of depression, but anxiety onsets way earlier in young kids at an age when they wouldn't have any potential to seek out support for themselves. So Project Empower was born because we wanted to be able to give parents skills and tools in their toolkit to support brave behavior and prevent anxiety from onsetting in their younger children. Parents can be, in some cases, key advocates and champions of their kids' mental health outcomes, and Project Empower aims to capitalize on that potential. Project Empower is based on research coming out of the Yale Child Study Center, led by Ellie Leibowitz and Wendy Silverman, on a program called the SPACE program. To date, the gold standard anxiety treatment for young people has been exposure therapy, which is it requires the kid to be there. But what Ellie Leibowitz and Wendy Silverman have been working on in the SPACE program is a parent-only treatment for child anxiety disorders. And essentially, what they found in their research is that teaching parents to build brave behavior and encourage brave behavior in their kids and reduce their own accommodation of their children's desire to avoid things that make them anxious, that alone works just as well as exposure therapy for kids who have anxiety disorders. So, given that there is this possibility of focusing just on parents and reducing mental health difficulties in their kids, specifically with anxiety, we wanted to see if we could create a single session parent-directed intervention that teaches parents to promote bravery in their kids and reduce accommodation. So Project Empower, we tested in a randomized controlled trial of 301 high anxiety parents to see if we could successfully help parents reduce the degree to which they accommodated their kids and improve their ability to tolerate distress that results from seeing their kid anxious, which of course, that's a key mechanism for why parents accommodate in the first place. In our initial RCT for Project Empower, we did find that the intervention significantly reduced parent accommodation of child anxiety and significantly improved parent distress tolerance. My awesome PhD student, Jenna Sung, who was the lead developer of Project Empower, just ran another RCT for her dissertation. And don't want to spoil her outcomes, but I'll just say that we were really excited about not just the short-term effects on parents' accommodation, but the longer-term effects on reductions in child anxiety. So really looking forward to being able to share that data with the world that Jenna has collected. And we've been able to partner with others, specifically Dr. Jill Ehrenreich-May's team at University of Miami, to translate and adapt Project Empower into Haitian Creole and Spanish in order to serve parents who ordinarily don't have access as easily to evidence-based treatment due to a limited number of providers who speak different languages. And we were really excited to find that Project Empower was acceptable in these linguistically, culturally diverse populations. Another approach we've taken to dissemination is really taking seriously the idea of meeting youth where they're at. Making things free per project, yes, was a good start, but it's not a sustainable model for reaching people proactively in ways that are going to connect them with mental health resources. Young people still ultimately have to find our website and choose to use it, which most of them will never do. So a much more effective strategy that we've embarked upon more recently is embedding single session digital interventions directly where youth already are on social media. To accomplish this, we've partnered with a nonprofit called COCO. COCO is led by Dr. Rob Morris, and it is an organization that contracts with social media companies and large internet platforms like Pinterest, Tumblr, Discord, and WhatsApp to embed mental health tools as just-in-time supports within those platforms. So basically, based on what people search for in those platforms, like if they search for suicide or therapy or self-harm, Coco will pop up and offer them resources at that moment. To date, or until a couple of years ago, Coco primarily was focused on offering peer support as a just-in-time resource. But we've worked with them now to embed our single session interventions directly into Coco's offerings so that they are now also offered as just-in-time mental health supports. And we conducted initially just a pragmatic evaluation, seeing how this went when we embedded our SSIs into Tumblr, which is something I used in high school, and I was initially surprised to hear it was still around, but it's used by hundreds of millions of people a year. So we integrated our SSIs into Tumblr. They were offered to folks based on their search patterns. In order to do this integration, we actually reduced the length of our single session interventions from about 20 or 25 minutes to about 6 minutes. Why? Because that's how long somebody will do something for if they're not being paid to do it as part of a research study, and it's a self-guided activity. We tried our best to still include those core elements of the intervention, meaning a narrative from a peer, an opportunity to give advice, some scientific explanation for why a skill could work. We were actually able to reach 6,100 teens over the course of 1 year, just naturalistically offering it within Coco. And what we were really excited to find here is that because we have RCT data as benchmarks for what effects to expect, we were able to estimate whether we saw a voltage drop in this real-world deployment of SSIs versus in our randomized controlled trials. And we didn't. Usually you do when bringing interventions out into the real world. You see a drop in effectiveness when it's scaled up, but we did not see that here. Hopelessness reduced at least as much in the Tumblr-based SSIs as hopelessness reduced in our RCTs, but completion rates for SSIs in Coco were a whole lot better than completion rates for our 20 to 25-minute versions. Not rocket science, because they were way shorter and easier for people to complete. So this was all very exciting to us. We've also used SSIs in collaboration with Coco, not just to target reductions in symptoms directly, but to target helping people increase uptake of resources in moments of crisis. So if you've been on social media and you've ever typed suicide or self-harm into a search bar, you've probably been faced with something like this automatic AI-generated pop-up that gives you the National Suicide Prevention Lifeline, now 988, and crisis text line. Unfortunately, although this is the standard across almost all social media platforms out there today, most people who are flagged as potentially at risk because of those search terms don't use these resources when they're offered to them. They see them based on qualitative evidence as impersonal, perfunctory, just required things that these platforms have to do to sort of cover themselves, and really not designed for them. So what we did is we partnered with Coco to make a 1-minute chatbot-based single session activity that included a quote from somebody else who'd lived through a suicide attempt and some evidence that crisis resources can help, as well as a choice of which type of crisis resource to try before offering a list of resources to folks. And that 1-minute SSI doubled in the moment uptake of online crisis resources within 10 minutes. As in an RCT of 355 young people who were identified as at high risk based on their social media activity, half of them were offered just the regular sort of pop-up, and half of them received the 1-minute SSI plus the pop-up. We saw a 38% uptake of crisis resources in treatment as usual, that pop-up alone, versus a 78% uptake of crisis resources when we added the 1-minute SSI. This is now Coco's go-to standard approach to offering people crisis support when they're detected in their partner platforms as having potential needs. We're really proud of this work and continuing to expand it as we expand our work with Coco. Another avenue to disseminating SSIs is making sure that they're optimized for the people they're designed to serve. This is something that historically intervention scientists haven't been great at. As in, we've often just sort of developed interventions within our own bubbles and then released them out into the world and wondered why nobody wanted to use them. Instead of inviting people who we're building the interventions for to co-design them with us. So to fill this gap, and given the many youth who identify as LGBTQ+, who participate in our research, we were really fortunate to get funding to pull together an advisory board of sexual and gender minority teens to help us revise our interventions to fit their needs. One of the first things we learned when we presented our SSIs for behavioral activation and growth mindset to this advisory board was they kind of just liked the interventions already. They didn't have too many recommendations for us into how to change what we already had, but they did really clearly emphasize to us that none of our interventions target oppression or systems of discrimination or the bias that they experience based on their identities. And the fear they experience based on the climate in the country right now about having, for instance, a gender minority identity. And they were totally right. And we didn't feel like we could just add that on at the end of a behavioral activation intervention. That would be wrong and probably received very poorly. So we decided instead to work with the teens to create a new SSI teaching about minority stress theory. We called it Project Rise. And Project Rise teaches people about what minority stress is, how it interacts with mental health difficulties and makes it legitimately harder for folks to cope if they hold certain minoritized identities, and what you can do about minority stress when you spot it in your life, and how to seek support and sort of safe spaces when those experiences emerge, despite an unfair situation that you shouldn't have to deal with. And what we found in our RCT of Project Rise, which we conducted on Instagram with 538 sexual and gender minority young people, we also obtained a parent consent waiver for this study, was that Project Rise significantly improved hopelessness, self-hate, and reduced internalized stigma versus an information-only control. And we're in the process of conducting larger scale studies of Project Rise to better meet teens where they're at, specifically those who are subjected to minority stress. Another intervention that we've worked on, shifting away from the digital, is one that is designed for humans to deliver it. The reason I wanted to develop an intervention for human delivery, not just online delivery, was that some people want to talk to a person. Online interventions are great, but they're not going to fill every gap there is in systems of care, particularly people who reach out for mental health treatment and, for example, are put on months-long waiting lists. Those people want to talk to a therapist, but they're not able to access one right away. We know from a lot of historical data that waiting lists actually cause harm. They're not inert. Telling somebody the moment they reach out for help that, good job asking for support, but hold that thought for 6 months to a year. We may or may not have somebody who can see you. That's harmful. That degrades motivation and it leads to worsened mental health while people are waiting. So the single session consultation is a solution-focused brief therapy intervention that we've been testing as a means of reducing hopelessness, increasing agency, and preventing symptoms from getting worse, specifically for people who are waiting on waiting lists for treatment, because that's a really high-risk time where people can really deteriorate. It's a really simple intervention based on solution-focused therapy, which is a strengths-based therapy approach. I won't go into all of the components of it, but the training is quite brief, and we've trained non-professionals to do it in multiple different contexts and across multiple different countries. This is the intervention, just to give you a sense of how simple it is. This is also freely available along with an intervention delivery guide and training slides. What we found in one of our open trials of the SSE, and the others that we've conducted affirm this outcome, is that among folks waiting for treatment, and this is people with all kinds of mental health problems, both teenagers and adults, we found that folks who got the SSE immediately after reaching out for help saw a significant reduction in hopelessness, a significant increase in readiness for change, and significant decreases in anxiety and depression even 2 weeks later. And we know increases in symptoms while waiting for care are actually the norm. So this was a particularly exciting trend to see. More recently, we've partnered with a really wonderful organization called Strong Minds, which aims to address the huge gap in mental health services in Uganda and Zambia, where mental health providers are extraordinarily scarce. Because even there at Strong Minds, they deliver peers to provide group-based interpersonal psychotherapy, but even they have long waiting lists because despite their scalable approach to treating support and mental health difficulties, there still isn't enough peer supporters to meet the demand. We trained some Strong Minds peer specialists to deliver the single session consultation to folks on their waiting list. And earlier this year, they carried out this trial, this open trial, that included 196 service-seeking Ugandan adults ages 18 to 69 with moderate or greater depression. And after receiving the SSC, either individually or in a group of 2 to 6 people, we tracked their depression symptoms across 4 weeks. And the majority of people who received the SSC reported subclinical depression symptoms at the 4-week follow-up. All of them had clinically elevated depression symptoms at the start. And again, given the patterns we expect for waiting lists of problems plateauing or worsening rather than getting better, this is really promising. One of the things we're prioritizing at this stage, beyond more RCTs, because we already have a bunch of those, is identifying strategic partners across multiple sectors to figure out how to sustain SSIs across real-world contexts. As one example, we're partnering with state mental health organizations to test out new pathways to billing for single session interventions. Currently, there is no Medicaid billing code for a single session therapy, because you always have to do an assessment before you can bill for treatment. And the assessment is the first session. So if you want to do a single session intervention for somebody on a waiting list, that's currently not billable at all, because you don't have a diagnosis for the person first and you haven't done an assessment. So we were able, at least in Pennsylvania, to get a waiver for a special temporary Medicaid reimbursement code that we're now testing out in a network of publicly funded clinics to see if we can demonstrate added value of the single session approach for waitlist folks. And if we can, then the state has committed to making the code permanent so that this can be offered as a service across the state indefinitely. We're partnering with other organizations like Mental Health America, which is an advocacy organization, Kuth and Alongside, which are companies, for-profit organizations that partner with schools to embed digital mental health supports, and Child Mind Institute, which is a national nonprofit, to explore different avenues to embedding SSIs along different systems of care and figuring out how these partners can be can play a major role in sustaining the evidence that we've accrued over the years. And before I end, I want to note one piece of the puzzle that I haven't really touched on, which is structural factors. Oh, Eric, any conversations with Optum? Yeah, we have a project with Optum integrating SSIs into pediatric primary care contexts, and I also consult with United Health about SSI delivery. So yes, happy to talk about that too. So I want to end by talking about one factor that I haven't touched on yet, which is structural and policy factors in all of this. One thing that we've come up against again and again is the reality, unfortunately, that no matter how scalable you make your intervention, it doesn't matter if youth are structurally disempowered from accessing the treatment that you build, as in if they can't access them because they're not permitted. And what I mean by this is we recently conducted a study where we asked 211 adolescents who self-reported having difficulty accessing mental health care, what got in the way when you wanted access to mental health services? And a third of them said their parents. Not necessarily that their parents were actively against mental health treatment seeking, although that was the case for some, but in many cases, they didn't want to burden their parents with their own mental health difficulties, or they just didn't feel comfortable going to their parents for support. Given that many youth across the country cannot are literally not allowed to access any form of mental health treatment without permission and active consent from a caregiver, this has huge implications for who can access and who can't access treatments, no matter how scalable they are. So our lab has made a foray recently into doing more and more work on consent policies around around youth access to mental health treatment. And we currently have grants from the NIH Office of Science Policy and from Hope Lab to explore teens' views on these parent consent policies that often restrict teens' independent access to care. We're doing some policy mapping work to get a sense of what are all these consent policies across states and how do they link up with access to care at a state level. And we're working on building a digital dashboard for therapists, teens, and administrators to streamline policy and advocacy change in this space. And lastly, as much as I love talking to other scientists about all of this, I think a big part of dissemination of science and results, it requires public communication. For that reason, I wrote this book on single session interventions, little treatments, big effects, that's specifically designed not for scientists, but for anybody, to hopefully make this idea more just a natural part of the mental health care ecosystem and conversation. That is all I had to share with you today. Thank you so much. These links are to various open access materials we have for the interventions I just shared, and happy to take any questions if you have them.
Wow, thank you so much. You have been busy. This is that's a lot. That's very cool.
Aiden's our designated gift for understatement. That is a lot. Bravo.
There's more to do.
Yeah, always, but you give me hope.
That's nice. So this was a single session intervention for hope for you.
And
Great.
I had multiple alarms that I was feeling significantly better. So I meant what I said at the opening, that I've been a fan of the work for a long time. I've been a professor for more than 20 years now, and every so often someone comes along that really changes the way that I look at things, and the field looks at things as well. But it's easier for me to notice when it's me. Your work changes the way that I think about social media. My wife is also at the University of North Carolina and runs the Child and Family Training Clinic. We've had a lot of conversations about assessment and a good feedback session as a single session intervention. And so I was jotting notes furiously, not just in the chat, but thinking about ways of connecting what you're doing with the clinic. There are like so many things that you're doing that are really neat and transformational and impressive. I'm one of your oldest fans, except that I know that's not true either.
Thanks. Well, that's really nice.
Do other people have questions or comments, or because I can keep going, I can keep gushing.
I just had one question. When you were talking about the SSI for the people on the wait list for seeking longer treatment, you had talked about hopelessness and depression symptoms, and I think depression symptoms went down, but did hopelessness also go down at a 2-week or the final follow-up?
We only assessed hopelessness at post because we think of that as a mechanism.
Okay.
But given that hopelessness is a symptom of depression, I would guess that it also went down at 2 weeks, but we don't have that data.
Very cool.
Taylor Scott in the chat asked if the single session interventions on the website have any form of risk assessment built in.
The ones on our website don't, because we don't have the capacity to respond to risk in the way that we would want to clinically. But we have a resource page. There's like a need help now button on every page of every intervention that links to a series of national resources for pretty much any kind of risk you would think of. For our RCTs, we actually ended up building a single session safety planning program, which is automatically offered to people who endorse non-zero suicidal thoughts or behaviors or self-injurious thoughts or behaviors in our intervention studies. So they get automatic safety planning support, even without access to a clinician, whether or not we can reach them by phone. So we do have that intervention available. And that's actually something that's really available on Project Restore, which is one of our other SSI storage websites. But the Project Yes tools don't specifically have risk assessments built into them.
And that makes sense to me as a fellow researcher. In the chat, I was impressed that you got the waiver for parental consent. That was SUNY Stony Brook.
We've done this at 5 or 6 universities now.
Yeah. It varies a lot from institution to institution, which
Yes.
is surprising to me because it seems like ethics are ethics.
You think that. The state laws have a lot to do with it, the consent laws.
So that's neat. And then what you said about the risk assessment piece also, that changes the calculus and figuring out. So you're really navigating that beautifully. You were talking about the translations, and you said that you have collaborators that have gotten things, at least one of the things, into 8 different languages.
Mm-hmm.
Is Brazilian Portuguese one of them?
No.
So Khalil Manara, we have people watching this right now live from Brazil. Khalil Manara is currently in southern Brazil, and one of the things that he's been working on is taking the HCAP speaker series videos and translating them into other languages. So he's worked out how to connect different AIs and automatic translations. And so we've been doing it in Spanish, and he says an acceptable version of Portuguese as well. So we're planning on making your talk available in multiple languages, and he may reach out. Isn't it? I'm like, wait, you're able to do this now? I don't know if you want to tell us a little bit more, Khalil.
Yeah. So hi, thank you for the presentation. Very cool, very impressive. So I cannot do it right now at this point, in the moment, because we don't have the resources built in for like doing it instantly. But potentially, like once we have the resources ready, that will be something very quick to do and so very easy to scale in terms of people getting to see you and understand what you're saying. And also we want to test how having the videos dubbed in the languages that people are speaking in can help further than just like having the subtitles on the videos. So that's something we're thinking about testing. But I wanted to do a question. Can I do a question?
Sure.
How do you make sense of like considering the results about how effective are the single session interventions in comparison with the long-term interventions? Like how can we make sense of the idea of a therapeutic alliance as a driver of therapy effects? Like what is happening?
So I don't think they're mutually exclusive. And this isn't data that I presented on, but in the single session consultation trials, we measure therapeutic alliance after 1 session. And it's we benchmark it against ratings, standard therapeutic alliance ratings that we see in multi-session psychotherapy studies, and the ratings are the same. So it's possible to create an alliance in a short period of time, which I think is counter to how a lot of people think about alliance. But ultimately, if you're talking about alignment between goals and feeling understood immediately and feeling like the person is on your side, that's all that a single session intervention is like trying to get it a specific way that your life can get better before the person leaves. So I think it could be a mechanism in both multi-session and shorter term therapy. So I don't necessarily think the comparative effectiveness is evidence against alliance mattering. I think it's just maybe alliance can take more forms than we're used to thinking about it taking.
Oh, yeah, thank you. That makes sense.
I'm starting off into space because one of the postdocs working with us is currently in Italy, but does a lot with therapeutic alliance and emotion in session. And so I'm sort of mapping what you're saying to him. And how much do you think, so is that you're assessing it at the end of the session, but how much of it is first impression, do you think? And how much of it is actually, hey, we did good stuff together? And there's also a difference between like feeling good about the person and feeling good about the work.
Oh, totally. I think the difference is in how you measure alliance. So, I mean, those things aren't necessarily the same as you're saying. But in terms of like what the therapeutic alliance effect is referencing in terms of like mechanism for effective therapy, I think most of the literature is more in the direction of like, we were aligned on goals and I felt understood by my therapist. That's how most of the common alliance measures are structured. So I think the science that we have would support the content, like the alliance of the in the sense of the work that you're doing mattering to the outcome rather than I like this person.
Yeah, he has read a lot of Gelso and also thinks more psychodynamically than I'm used to. And
Yeah.
so that he thinks a lot about the real relationship and is the person being genuine or authentic with me. And so that's one of the things that he often focuses on.
Yeah. It's interesting. I think that feeling of like being your true self or authentic self, that's something that we've found qualitatively at least can happen even in a digital program. Because people are asked to express themselves and to give advice to others and to read stories of people who are like them. And people often say that they feel understood and connected to the SSIs that are digital and don't involve a human, even though they know that there's no person. So I think there are a lot of ways to get at alliancing, including the kind that you're talking about.
With where a lot of the AI and image generation and things are going, I know people are playing with using different avatars, and so there's discussion around like, do you get more engagement if the person can design their own avatar, or if it's designed to look like them? This is a bit of a weird angle, but I remember, I'm never going to forget, one of the first supervisors that I had when I was in graduate school was a social worker that we were working in community mental health, working with kids, and he had a picture on his bookshelf of some kids. And I'm like, oh, are those your children? And he's like, no, but sometimes if parents assume that they are, I go along with it as a way of trying to get buy-in or credibility about what I'm talking with them about with parenting. And the disconnect, the thing that I'm not forgetting or what I'm stuck on, I hope pops for other people of like, it's like a white lie, but in the service of trying to help people. And I'm like, is that okay? Is that not okay? I I decided that wasn't okay for me. Like that didn't
Yeah.
feel authentic for me to copy, even though that was my supervisor. But 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 for me, it's like, well, at what point, at what point, if we're making an avatar deliberately to look like somebody or something, are we
Yeah.
getting close to that line that he was crossing?
Yeah. I think it comes down to like how much is the person using the tool aware of what the tool is. And I don't know. It's very complicated, but AI is quite the rabbit hole to go down in the space.
Yes. Yeah. And the more immersive it is, the less sort of it's like designed to make us less aware of.
Right.
So, anywho, I became aware that you were reading the chat much more than I do typically when I'm presenting. So you already saw a lot of the shout outs and double downs and the oh, and Bree has a question in the chat. Do you want to speak it, Bree, or do you want Aiden?
Oh, interesting. Yeah, so there's a lot of evidence around in terms of like the frequency of sessions. There are many ways to do therapy effectively. So starting monthly, I mean, we don't have any evidence on the pacing of sessions for people actively seeking multi-session therapy. And in fact, the research suggests that more frequent sessions closer together may be more helpful than once weekly sessions further apart. Even the same number of sessions, they'll be more helpful if they're closer together. So that goes to like intensive treatments, brief and concentrated treatments for different types of problems. I don't necessarily think our research suggests that monthly sessions will be better than weekly sessions. But using the first session that people have, or taking a single session mindset even into each session, is something that I have frequently advised my clinical supervisees to do. And that way, you're at least optimizing the opportunity for each session you do have to make a dent that's meaningful. And to potentially spur more of that progress that can happen early on in treatment to happen as much as possible. So yeah, I don't think our research really speaks to the spacing of sessions being more helpful one way or the other, but it does potentially speak to how to treat each individual session as a standalone service rather than as a lead into the next thing.
Any other questions in the room? I know we've got a live audience at Hal. Thank you a ton. This was a wonderful presentation. You packed a huge amount into the talk, and you packed a huge amount into the career, and it really was a wonderful bird's eye view of that. I just want to reinforce yet again, like, been doing this 20 years, you're accomplishing a lot of things that are not only innovative, but really impressive, very rare. You keep pulling rabbits out of hats, and the rabbits are scalable. It's like Rabbitzilla, a giant rabbit that's
rabbits are good at scaling, for what it's worth.
Right. So huge impact for a lot of people. It's really exciting to hear how you're already collaborating with people in other countries and transforming systems of care. And Aiden has a question, but I also just wanted to say thank you for doing this for HGAPs. So we
My
have
pleasure.
people zooming from multiple states, multiple countries. As I'm looking around the tiles in the Zoom, I know we have people that are bilingual in many different languages. So there's so
Awesome.
many angles that your work is really inspiring.
Thank you.
And now that Aiden has his mouth full.
So Cameron had a question which reminded me of my question, so I'm just going to ask them both. So at UNC we have a new course called College Thriving, which is how to navigate college as like an academic space, but also like a well-being, or like how to keep a decent well-being during college. And part of it includes like curriculum on mental health and well-being as it relates generally and as a university student. Do you see your work being applicable in a curriculum like that? And like, is it helpful for people who may not be presenting with any like psychopathology?
Yeah, so we've done some school-based studies that are sort of like school-wide deployments of these kinds of interventions. And like, for example, we deployed Project Yes in San Antonio to entire schools of students. And the magnitude of the effects is smaller when people have no room to move, when they're doing great. But they remain acceptable, and we still see movement in those targets that we care about. And in some studies, even in longer term outcomes, like lack of worsening of depression symptoms over time compared to a control group rather than reductions. So in high school students, for example. So I think they're most helpful for people who perceive an acute need for support at moments where they perceive that need for support. But that's not to say that it can't be helpful in a more prevention type approach. I do think, the outcomes of interest in prevention studies are probably different than the outcomes of interest in mental health treatment studies. And that's not work that we've done yet, but I do see some potential there. I also see a risk of making them mandatory. So like
Schools
curriculums.
would never do that.
No, they hate mandatory things. Everything's totally up to kids. So like the school assembly approach to mental health treatment, and prevention, they will zone out, they'll hate it automatically because it's a top-down thing that is, it's being imposed upon them. It becomes homework. So I think there has to be some thought and care as to the dissemination strategy of these things in school and sort of, campus-like contexts to preserve people's autonomy and using them where and when they want to. So I think yes, and is the answer to your question.
Well, and that's interesting too, because HGAPs originally got a sneak peek at what that curriculum looked like, and we're like excited about it. And now hearing about how it's been implemented years down the line, it is interesting with the freshmen and sophomores to talk about it in a not so positive light. And it never really honed in on it being due to the mandate or due to it being mandated.
Yeah, I do think that autonomy piece really matters, and how much ownership people feel over an intervention, especially younger people, really makes a difference.
Does anyone else have any questions in the room? Okay. Thank you so much for your time, Dr. Schleider.
Thank you.
I do. What positive comment or feedback felt most meaningful to you?
There were so many. I think that the comment that it changed the way how you think about, what interventions can look like and how to do this work, that's probably the most meaningful. You mean in this talk or like
I'm
ever?
glad you heard so many. Yeah, no, we really have been looking forward to your doing this with us for a long time. Thank you.
Oh, thanks. Yes, and anyone who wants to follow up, please feel free. You have my email. Okay.